Hello and welcome to today's webinar. This webinar is a part of the joint series between Excel Catlin and the Sullivan Group. Today's presentation will be on creating a culture of safety with Dr. Arnold Mackles. Before we get started, please note that this is a recorded presentation like many before it. The list you see before you is a list of our archived broadcasts of prior webinars in this series. You can find these recordings on the Sullivan Group's YouTube channel or on the webinars page of thesullivangroup.com. Before we get started, if you have any technical difficulties during today's program, feel free to chat with the organizers or email me, jpiche@thesullivangroup.com, Jpiche. Additionally, if you have any ideas for future webinars, we'd love to hear from you. Again, you can email me at jpiche@thesullivangroup.com with those ideas. And finally, there will be a question and answer session at the end of today's broadcast. We'd love for you to collect your questions throughout today's webinar, and you can throw them into the questions or chat box, and we will address these at the end of today's presentation. So without further ado, I'd like to introduce Dr. Arnold Mackles, who will be leading our discussion today on creating a culture of safety. Dr. Mackles, the floor is yours, and thanks for being here.
Thank you so much, Jenna. I'd like to welcome everyone to this webinar on creating a culture of safety. The program today will examine the characteristics required to create a successful culture of safety in healthcare institutions that can be highly effective in reducing medical errors and in basically improving overall care for patients. The learning objectives we have for today are, number one, to be able to outline the characteristics of a culture of safety. Number two, to define the feature of high reliability organizations. And three, to utilize strategies to improve communication in healthcare settings. So let's get right to work. I want to start with talking about the National Patient Safety Foundation. In 2015, they came out with a report that was entitled Free from Harm, Accelerating Patient Safety Improvement 15 Years After to Err is Human. As I'm sure most people who are on this webinar are aware, back in 1999, just before the turn of the new millennium, the Institute of Medicine came out with an important and really earth-shattering report. The National Patient Safety Foundation, in the 15-year after report, basically stated that patient safety concerns remain a serious public health issue. The report, as you know, was entitled To Err is Human, Creating a Safer Health System. And the report basically estimated that there was a hospital injury in 1 out of 25 patients, as well as a death rate of anywhere from 44,000 up to 98,000 deaths per year from medical medical errors. Now, keep in mind that over the years there have been a few different reports, and you may be aware that about a year or two ago a report came out of Johns Hopkins University Medical Center by a Dr. Macari, and this made national news. Basically, it stated that there were over 250,000 deaths per year from medical errors in the United States, which made it the third leading cause of death, which was pretty unbelievable as a statistic. Now, keep in mind what Dr. Macari did was use older studies over the past 15 years and then extrapolated using the 2013 hospital admission rate for the United States. The report that came out in 2015 from the Agency for Healthcare Research and Quality made 8 recommendations. And I want to focus in on the first one because this is obviously the most important. And I think this will have the most important relationship to improving medical errors and creating safety in the future. And that was, number one, ensure the leaders establish and sustain a safety culture. If we don't have the information and the force coming from the top of the organizations, it's not going to work. So the leaders have to really not only put out these initiatives, but have to really walk the walk and talk the talk so people throughout the organization will really buy into it. Now, what is culture of safety? Well, a very simplistic definition is it's what you do when nobody's watching. We know that you have to adhere to high standards of patient safety and medical prevention protocols at all times, but in reality, the definition is much, much more than it's just what you do if nobody is watching. Other industries, in particular the aviation industry and the auto industry, are way ahead of us as far as patient safety goes. And a lot of this originates from methods used in the military. And an early definition for safety culture for aviation is the following. A safety culture exists within an organization where each individual employee, regardless of their position, assumes an active role in error prevention, and that role is supported by the organization. However, more specific definitions for use in healthcare have the following characteristics. Number one, understanding of the organization's high-risk activities. And we all know in healthcare, we have a lot of high-risk activities going on. Then, the next would be constant striving for safe operations. Everyone in the organization has to constantly strive to make things better. And probably the most difficult characteristic is to create a blame-free environment with transparent reporting of mistakes without fear of punishment and reprisal. And as I go around the country lecturing and training doctors and nurses, I think this is the most difficult area for administrators to try and get buy-in on. Other characteristics, collaboration. There must be collaboration across all hierarchies and specialties to create patient safety safeguards and resolve safety issues. We have to really break down the hierarchies. We know that there are hierarchies exist all throughout most industries, and we have it in hospitals as well. Just think of the operating room with a hierarchy of the head surgeon, and then the assistant surgeon, the anesthesiologist, the scrub nurse, the circulating nurse, and even the housekeeping who cleans the floor. We have these hierarchies, and we have to really collaborate amongst these different hierarchies as well as through different specialties in the hospital. Then we have encouragement. As I mentioned before, top leadership has to encourage the rest of the organization. They have to be visible and open to suggestions and open to working with everyone in the organization. There must be a commitment of the organization to provide resources and to effectively address safety issues. Now, the initial concept of a culture of safety was really taken from high reliability organizations. And these are organizations, for example, in healthcare, we see that in the environment of healthcare practice is complex and requires coordination of teams. In these high reliability organizations, there's an emphasis on safety, minimizing errors, adverse events, as well as catastrophic situations. But overall, there's a commitment to safety throughout the organizations, and we're going to talk more about high reliability organizations. High reliability organizations are organizations with systems in place that are exceptionally consistent in accomplishing their goals and avoiding potentially catastrophic errors. Perfect example would be an aircraft carrier. On aircraft carriers, we know that planes land and take off almost every minute or two. There's frequent changes in weather and wind that the crew has to adjust for when they're landing planes and planes are taking off. It's extremely high stress, and there's lots of pressure on the crew to perform. So when we have high reliability organizations, we need systems in place that prioritize safety, anticipate danger, and constantly adjust. And we really need to do the same thing in healthcare because lives are at stake every day in the work that we do. So let's talk about some of the characteristics of the high reliability organization. First of all, there's a preoccupation with failure. People are always thinking about threats and what could go wrong. Near misses are seen as learning opportunities, and we have to take advantage of this in our healthcare systems. We have to make it easy for people to report near misses as well as medical errors. And near misses we can learn so much from, and I think people are much more willing to talk about near misses than an actual error where a patient is harmed. There's also a reluctance to simplify. There must be an understanding that the job is complex, and you must seek detailed rationales rather than quick, simple answers. For example, if If a nurse gives the wrong medication at a bedside to a patient, the easiest thing would be to say, oh, the nurse gave the wrong medication, the nurse made a mistake. But in fact, what we do is we need to do a root cause analysis and figure out, why did that nurse make that mistake? Was it a look-alike medication or sound-alike medication? Did something go wrong in the pharmacy where the wrong medication was put into the cart? Or does it go all the way back to the manufacturer? Did the manufacturer manufacture a vial that looked exactly like 2 or 3 other medications in different concentrations? So we can't just simplify. We have to figure out the exact mistake and then put an exact fix into the problem, into the solution, I should say. High reliability organizations have a sensitivity to operations. Personnel are sensitive to the situation around them and how it could create an unsafe or threatening situation. This is often referred to as situation awareness or big picture understanding. And we have situations like this all the time in medicine. My background is in neonatal medicine, and there are many times throughout the years where we'd be really overworked and we'd have lots and lots of moms delivering babies, and a lot of sick babies might have resulted from that. In particular, we know that for example, a lot of babies are born in September and October, probably the highest months during the year. So during those months, we have to be prepared for anything to happen. We usually have so many deliveries that we have to make sure that our surgical suites, our C-section suites are available and backup systems present, and make sure that we get them cleaned and turned over quickly because we never know what may be coming down the pike. And that is really situation awareness or big picture understanding. There's a deference to expertise. HRO staff and leadership understand that the frontline workers are often the most knowledgeable about the complex tasks and sophisticated equipment. So in preparing for and during emergencies, the hierarchy must defer to the most experienced individual. For those of you who have clinical expertise, it's very common that the nurses at the bedside know a lot more about what's going on with their patients than, the professor who's making rounds. And they're much more familiar with the equipment in many cases. A perfect example from history about deferring to expertise, we get from even going back to World War II. In the Allied invasions of Europe, in particular the invasion of Italy, the areas of Italy, when these invasions would occur, of course they were led by the chief, the leaders, the generals and the people high above who planned the invasions. But what came to pass was that there were a lot of privates in the troops who were Italian Americans who grew up in their younger days in those areas of Italy. And so the leaders of the invasions often deferred to the people who knew the terrain of the land the most to use them and their expertise of how they should move the troops and what they should use for advantage points and so on and so forth. So we have to work as a team and often use the people who know the most, which may not be the people in charge. There must be a commitment to resilience. People in HROs assume the system is at risk for failure. That's a given. Performing rapid assessments and responding appropriately to dangerous situations is required. So in an HRO, people are always thinking of backup plans. What should I do if this happens? What should I do if that happens? And they're constantly thinking of ways to take care of the situation should they arise. Now, any discussion of patient safety and a culture of safety must include a just culture. And what a just culture is, it's an addition to it, and it adds accountability to the blame-free environment. Although we want to have a blame-free environment, we can't totally let people do whatever they'll do and without some kind of responsibility. So a just culture really states that there's zero tolerance for behavior that is considered reckless. And the administration response to errors has to be related to the associated behavior rather than the type or serious of an event. In particular, we must make distinctions between a human error, which might just be a slip-up mistake, versus at-risk behavior, where a nurse or a doctor may be using shortcuts to get the job done. And the worst would be reckless behavior. Example would be refusing to follow safety policies and protocols. So the administrator has to look at the situation. Even if a patient was really harmed, but it was a human error, they have to deal with it in a certain way that's really not very punitive. Whereby if there's reckless behavior that an employee or a doctor has been using, now that has to be have some level of punishment. Let's talk about measuring our safety culture. I don't know if any of you in the audience today are from the Northeast, but I did my training in New York City, and you could tell from my voice that I'm a New Yorker from where I'm born. And there was a mayor of New York many years ago by the name of Ed Koch. And Ed Koch he served several terms as mayor, and most people really loved him. But he used to go around the city, and he used to say, "How am I doing? How am I doing?" And, the answers really reflected the individual citizen, what they thought. Either, yeah, you're doing great, or no, we don't like this. But it wasn't a very scientific test. And really the same has been true in healthcare for many years. Until recently, healthcare organizations had no way of accurately measuring or benchmarking how they're doing. How is our safety culture? We had no idea. And so the Agency for Healthcare Research and Quality developed surveys exactly on the topic of safety cultures to survey hospitals so we could find out what we're doing. And the first one came out in 2004. Since then, the Agency for Healthcare Research and Quality has made available surveys for all different areas in medicine, for medical offices, nursing homes, community pharmacies, as well as surgery centers. Data has been obtained on thousands of providers. It's a huge database, and we can really use this for deciding how we're doing, and it allows for research and benchmarking as well. Now, organizations can use these surveys for many different reasons. We can use them to raise staff awareness about patient safety. Just by having the survey makes people think about patient safety. They can be used to analyze current organizational state of the patient safety culture. They can be used to point out areas of strength and weakness in their culture, and we're going to do that. We're going to show you some information about one of the surveys about the strengths and weaknesses of organizations, and I recommend that every organization partake in surveys so you know what's going on in your organization. And through these surveys, we can identify areas that really need to be improved and worked on. Such surveys really help us understand the trends in our patient safety culture. We're able to review successes and failures of initiatives in patient safety that the organization may be using currently or in the past, and can help us plan for the future. Benchmarks can be done within the organization as well as externally. You can see how your culture and how you're doing matches up against the hospital next door or the hospital in a different state or different part of the country. But overall, I think this helps keep the staff engaged with patient safety initiatives, where you can really tell from these surveys, are your initiatives working? And if they're not, you really need to go back to the drawing board, because patient safety is the future. And as we go into the future, especially with changes in healthcare, in government rules and regulations, and healthcare reform, hospitals that have good patient safety will do well, not only financially, but as far as medical legal situations are concerned. Now, historically, since these surveys were started, we've learned a lot of interesting things that we never thought, were present, but we're learning so much about them. One particular survey that the AHRQ uses is the Safety Attitudes Questionnaire, or the SAQ. And when they gave this out, they realized that safety culture is a local phenomenon. It's local and individual to the specific organization. Safety culture not only varied from hospital to hospital, but it varied from unit to unit within the same hospital. So in your hospital setting, you could have one culture in the operating suite and a totally different culture in the emergency department or in the Department of Radiology. So it really varies. And what we have to do is we have to make sure that whatever culture is growing in our organizations, it's based on safety and based on proven rules and regulations and outcomes that are safe for our patients. Here's an interesting finding that the SAQ survey found. Safety culture varies significantly among different types of providers. In one hospital setting, 80% of surgeons responded that teamwork was strong. Yet in the same setting, only 25% of OR nurses agreed. So different people in the hierarchy and in different specialties see things differently. And our job going into the future is really to get these different hierarchical levels as well as different specialties on the same wavelength, get them speaking the same language, so to speak, so they can work together, because it's very difficult when you have such a diverse percentage of individuals feeling opposite way. Now, safety culture is perceived differently by caregivers and administrators, the same way it can be perceived differently from the surgeons and the OR nurses. Frontline workers had more negative views of safety culture than managers in recent surveys. So if the managers find this out and realize that whatever they're doing, they're not on the right plane, they have to reassess in how they're approaching their workers. Let's talk about an actual survey that occurred fairly recently. This is the 2016 AHRQ Hospital Survey on Patient Safety Culture. And it was a very big survey. They looked at 680 hospitals. There were over 447,500 hospital staff respondents. There was a 42-item survey that measured 12 components on patient safety culture. And what do we find as survey results? Well, they found areas of strength. Let's talk about the areas of strength. When it came to teamwork within a hospital unit, there was an 82% positive result of respondents feeling that there was good teamwork. When it came to manager-supervisor actions promoting safety, it was 78% positive. And for organizational learning and continuous improvement, it was 73%. Now, this survey, as I said, was done in 2016. I will point out that recently data has come out for the 2018 hospital survey. But keep in mind, it was a little bit smaller. There were only 630 hospitals used, and they only had 382,000 approximate respondents. So it was a smaller survey. But what I find totally interesting is that there was a 2-year difference, and in the most recent survey, the results are pretty much the same. When it came to teamwork within a hospital, you had an 82% positive. When it came to management support of patient safety, it was 80% positive. And for organizational learning, it was 72%. So basically, 2 years apart, 2 surveys show the same results. Now, I believe we're going to have a little questionnaire to poll the people participating today about your own hospital organization, so we can compare that to the national average on a particular question. And Jenna's going to prepare that.
Yes, thanks, Dr. Mackles. So I've launched a poll here, and if you could please vote and let us know, does your organization have a non-punitive response to error? If you can rate your organization 1 being very punitive response to error to 5 non-punitive response to error, we'd love to see how your responses measure up to what the survey found. Any response that you put in here will be anonymous. We'll just be able to see the numbers and not specific names. So we'll give you a minute to go ahead and vote here on how you feel your organization fits. A few more seconds and we will close up this poll. All right, I am closing it up now and we'll chat about the response. So Dr. Mackles, for your knowledge, we had 5 folks, 29%, answer that they have a non-punitive response to error. 43% said their organization was at a 4, and 29% said their organization was at a 3. So the majority of us are on the higher end of that scale, which is great to see. So back to you.
Okay, so now let's see what the survey showed. I'll show you the results for 2016, and then I'll tell you the results for 2018. When it comes to non-punitive response to error in the 2016 survey, there was a 45% positive response. When we look at the same that occurred 2 years later in the 2018 survey, it was very similar, but it was 47%. It just ticked up, a couple of percentage points. Okay, that's really interesting to know. Thank you all for participating. Let's go on with our survey results, and these are the areas that really need improvement. As we see, non-punitive response to error in the survey needs significant improvement. The next one is a really big topic, handoffs and transitions. There was only a 48% positive result in 2016 when it comes to handoffs and transitions. And for the 2018 result, it was also 48%, exactly the same. And I really believe that that's how people feel and that's what's going on, because as I go around the country and I do a lot of lecturing and training doctors and nurses, the topic that's asked for the most is on handoffs, transitions, and discharges, because that's when we make these communication errors. We see it more severely in teaching hospitals because, interns and residents are just learning how to do handoffs and transitions. They're just learning about medicine. And we're finding out that that's where a lot of the mistakes occur in teaching hospitals, but in any given other type of hospital, this is a real major problem. And I think we really have to do a lot more work on teaching handoff techniques, because there are simple techniques such as S-bar that probably most of you have heard about, or another one that's now called I-pass. That's a really simple handoff technique. And now a technique like I-pass integrates the computer. So that at time of handoffs and transitions, the computer will print out a handoff sheet that will be discussed by the sender to the receiver and actually physically hand it off. And often the computer will remember a lot of things that the doctors and nurses who do the handoffs just don't remember. So I think that the future is going to be integrating the computer. The next topic that needs improvement is staffing. I have to admit, I have never been to a hospital anywhere, not only in this country, but other countries, where people think staffing is 100% great. It's just not. So I think that's an ongoing problem, and as we run into more and more financial issues in the future, I think that's going to continue to be a big problem. Since we're on the topic of handoffs and transitions, we just saw how poorly the respondents felt about that in the national surveys. Back in 2006, the Joint Commission came out with a national patient safety goal for handoffs to standardize handoff communications, and that was in 2006. And here we are 11 years later, a year ago in September, just about a little over a year ago, in September 12th of 2017, the Joint Commission had to publish a sentinel event alert on the topic of inadequate handoff communication. Now, Now, the Joint Commission comes out with these alerts probably about 2 or 3 times a year. When they see a rash of problems in one particular area of medicine that's causing issues, they will put out an alert where they'll tell us about the problem, what to look for, and how to deal with it, and some recommendations. And here we were 11 years later, they had to come out with another Sentinel event message about what we're doing with handoffs. So I think this is an area that as patient safety leaders, we really have to focus on going into the future. Program components. These are basically components of the patient safety protocols and patient safety policies that we're setting up. What we should keep aware of is that culture is really interrelated now with healthcare reform. Federal legislation has really changed the playing field for hospitals and providers. Reimbursement is based on performance and value rather than how often a doctor sees the patient or procedures that you're doing. So providers are evaluated and compared on safety, value, patient outcomes, and patient satisfaction, and that's how reimbursement is based on a lot of safety issues, value, and patient outcomes, as well as patient satisfaction. So safety culture of an organization will play a major role in the future viability and financial success of the organizations. Hospitals that do well with the future of healthcare and reimbursement policies, will do well financially and hopefully will be the safer places. So it's something that everyone should really strive to do. So when we look at the components of patient safety culture, let's start with input from top leadership, because this is the most important. If leaders come out with initiatives, but they don't really back them up, or they're not visible working on them, hospital employees and staff are not going to buy in. I really believe that administrators need to have an open time where people can come to their office, even if it's only a half an hour a week. They can come to their office and discuss things, come up with ideas, mention things that they think are going wrong, and then the administrators have to really respond to that and show that something is being done about it. Leadership needs to have a vision of the safety culture, and in order to have a vision, you have to be able to review adverse events, evaluate safety, and then perform a gap analysis on the safety culture to see what needs to be changed, as well as instituting appropriate safety measures after you know what you're doing. So there has to be a total vision. It has to be organized. All personnel must be included in the patient safety culture. Everyone in the organization needs to be involved in initiatives as you determine by your gap analysis and your evaluation in that vision I talked about in the prior slide. We have to be able to adapt to the safety needs of an organization. And you can't use a cookie cutter because all organizations are different. Every organization has its own thing. You can't use the same program for an inner city urban hospital versus a small rural hospital. You have to personalize it for the needs of your organization. And you have to be specific if you want to change the culture in your organization. There must be consistent commitment to safety. I stress the role of top leadership, but governing boards of hospitals, again, as I said before, must walk the walk and not just talk the talk. Governing board meetings should have set times where they will talk about safety issues. They should invite risk managers to come in and talk about the malpractice issues going on and other safety issues and how to deal with them. So governing boards should not just be about the financial status of the hospital and building programs. They really should include this in their meetings. And they must avoid the defunding of safety initiatives once they're started, because that, what message does that send to the staff? It sends the message to the staff that it's not that important, when in fact, the future success of the hospital is really based on patient safety. And again, medical errors must be responded to with changes in the system. You don't want to just, fire the nurse if the nurse made a mistake. You want to fix the problem that may have allowed that nurse to make the mistake in giving the medication, as we talked about before. You want to change the process in the system. And again, we must transcend the leadership. Culture must transcend the leadership, meaning the culture needs to be embedded in the organization, and if you have a change in leadership, it shouldn't affect the culture. I worked for one hospital for many years, over 20 years, and looking back, every 18 months to two and a half years, there was a new CEO, and every time a new CEO came in, they blamed the old CEO for the problems and then try to create their own leadership roles and initiatives, and then it would change again. So it's very difficult if the culture is going to change every time someone new comes in. So the culture needs to really be embedded in the organization. The last major topic I really want to stress and talk about is communication and safety culture, because it's really all one and the same. And I'm a believer that it's all about communication, and I have data to prove that. When it comes to malpractice, risk, and communication failures, there was a report that came out by CRECO. CRECO is the Risk Management Foundation of the Harvard Medical Industries Incorporated, and they have a huge data bank, okay? They have great, they just have great data to draw from, and they did a study on malpractice cases, on closed malpractice cases, which are cases that have come to fruition. Either they were dropped or they were mediated or settled between the two parties, or were adjudicated in court, but they were completed and closed. They did a study and made the statement that communication failures were linked to 1,744 deaths in 5 years. They looked at a huge amount of malpractice cases. They looked at 23,685 cases from 2009 up to 2013, and they evaluated them. And they identified 7,149 cases where communication failures caused patient harm. Communication failures, not the doctor's knowledge or the doctor's training or the nurse's ability, communication failures. That's about 30%. And if we can cut down on 30% of our malpractice cases just by communicating properly, it's something we really should do. Now, where do these communication errors occur? Well, for many years, since most of the research was done in hospital settings, everyone thought that, errors occur in hospitals. They don't occur in private offices. How wrong this was. Now we know that communication errors occur everywhere. They occur 48% in ambulatory settings, meaning clinics or doctors' offices, 44% in inpatient settings in hospitals, and 8% in the emergency department. So they happen everywhere. And if doctors and nurses think they're safe from these errors because they work in private offices, they have a lot to learn here. And we're all learning. So this is, great experience because we never knew this information before. Now, the results of the CRECO report were pretty fantastic, and so they came out with some recommendations. First one is to use empathy. Have and display empathy for the patient's situation. Consider emotional aspects when delivering diagnosis, treatment plans, and complex scientific subjects, because compassion plays a major role in efficient and effective communication. And some earlier studies really showed that patients who have a good rapport with their doctors and like their doctors sue their doctors less. Next topic that they recommended was to have an effective consent process. Some organizations are even creating legal yet patient-friendly consent forms. And during the consent process, you should discuss everything: expectations, outcomes, effects of obesity and smoking that can have on the surgical procedure that you're going to do, whether blood products are used, are there going to be any sales reps in the operating room that you didn't know about, when you're putting in certain devices, what kind of anesthesia is using. And now, in this day and age, you really need to discuss what kind of pain medication you're giving the patients afterwards. And, is there any relationship to the pain medication they're getting and addiction? So it's something very important, as well as will there be photography. And everything should be documented in the conversation. And while we're on the topic, I have to mention that now that we're using electronic medical records pretty much everywhere, one of the pitfalls of electronic medical records is that often the consents are signed, but they're not getting scanned into the record. And if they're not in the record, as you all know, that most doctors and nurses learn the first week of training, if it's not in the record, it didn't happen. All right. So legally, it's really important that it gets scanned into the record and the conversation is documented. And finally, the third recommendation was there should be a family and friend communication system. Some hospitals are using innovative programs with in-room tablets and patient portals, such as Beth Israel Deaconess Hospital in Boston, that provides information on the care and where patients and their families can ask questions on the portal and have the providers respond to them. Okay, this slide is, I call it my take-home lesson slide. When I give lectures on preventing medical errors or communication in healthcare, this slide is the take-home lesson because it tells you what it's all about, why we make these mistakes. This slide shows the most frequently identified root causes of sentinel events reviewed by the Joint Commission by years, and I have 3 years of data, 2013, 2014, 2015. Now, in any given event, there can be more than one root cause leading to the event, okay? But when we look at the order of frequency, what are the most frequent root causes? In 2013, number 1 was human factors, number 2 was communication, 3 was leadership, and then 4 assessment. In 2014, similar with a little change, 1 is human factors, 2 leadership, 3 communication, 4 assessment, and the same exact thing we see in 2015. Now, what were doctors and nurses trained in? We were trained in how to assess a patient, how to diagnose a patient, and treat the patient. That's what our training was all about. We were never given any formal training in human factor engineering or communication techniques or leadership. If I happened in my training to have an attending who had good bedside manner, I would sort of try to emulate that and learn from it. But I was never had formal training in it. And as far as leadership goes, yeah, there were good leaders and bad leaders. I didn't know anything more about it than that. But everyone today expects doctors and nurses to practice with perfection. Yet the top 3 causes of medical errors we had absolutely zero training in. So therefore, I believe wholeheartedly that it's up to the industry. It's up to hospitals. It's up to insurance companies. It's up to legal companies to train doctors and nurses in these techniques so we won't make these mistakes. And I'm a big believer in communication because it's probably the easiest to teach and the easiest to learn. There are so many techniques we can use that make communication and handoffs, appropriate and effective. All we have to do is talk properly or type properly or write it into our charts and our notes properly. So this is the field I think it really behooves us to train our docs and nurses in training they never had before. And I think that's the way, if we're going to reduce medical errors and create a safer future, that's the way to do it, through communication. Okay, in conclusion, I want to thank you all for partaking in this afternoon webinar. And I think we have a lot of current challenges. We're all aware of the financial situations and the stress that a lot of the older doctors I know have in using medical records and making things safe. And now especially new issues that we're seeing with the opioid crisis now. I think we're going to have a lot to work on from patient safety, because we're going to have a whole group of patients that we have already that we have to make sure that in the future we treat them in a very safe and healthy manner. And there are lots of other new issues that are popping up. But I do want to stress that I think we have a bright future, and the future is bright. And the reason I say this is a couple of years ago I was asked by the Florida Medical Association, which I'm a member of, to be a judge at their annual meeting for the poster contest. They have a program now where they ask medical students as well as interns and residents from all of the hospitals and organizations around Florida to do research and present poster sessions of their research. And so I agreed to be a judge, and it was the hardest thing I ever did because there were so many brilliant posters and brilliant researchers with these young medical students and doctors coming up with all these great ideas for taking care of patients and new software programs to help take care of patients. And there was so much fantastic information there. And I met so many young, wonderful doctors. And I just think that the future is very bright because in today's world, these young doctors are going into the field knowing what it's all about and knowing that it's not going to be, a financial panacea. They're going into it for the right reasons, and there's a lot of bright people, and that's why I think we have a really positive future to look forward to. Thank you so much, and we'll be happy to take some questions.
Thank you very much, Dr. Mackles, for that great presentation. I have a couple questions that have already come in, so I'll go ahead and pose those to Dr. Mackles. But if you have others while we're sharing these, please go ahead and type them into the questions and the chat box. So, Dr. Mackles, our first question for you comes from someone who has a comment first. She says, our hospital communicates pretty well within its walls, but we don't have as much control when the patient goes home. Do you have any recommendations to improve communication after discharge?
Yes. There are programs out there. There are models called transition of care models that basically start getting the patient ready for discharge on admission. There's a team of various people in the hospital that are assigned to the team and assigned to a patient, whereby as the patient moves from, let's say, the emergency department to intensive care to a step-down unit and then gets ready for discharge, the patient is instructed each step of the way, not only in the care they're getting, but who is the person in charge, what they may have to start thinking about for discharge. And everything is planned, and the patient really becomes a partner in the care. And at the time of discharge, before the patient goes home in these programs, everything is organized. They know when their doctor visits are, they know what their medications are, they've been instructed on how to take them, they know that they have the money to pay for it, who's going to drive them home, who's going to pick up the prescriptions. And then a day or two later, they get either phone calls or visits from people at the hospital. Often a pharmacist will call to ask how they're taking the medications to make sure that it's appropriate. And if they don't have rides to the doctor, this is all arranged. But since we're on the topic of discharges, I have to tell you the major complaint and major issue I hear around the country from primary care providers is that the hospitalists do not communicate with them. A patient will show up at their office after being in the hospital, and the provider, the patient's provider didn't even know they were in the hospital in many cases. Other cases, the provider might have known they're in the hospital and they don't have the record. There's studies been done that's showing that only like 40 to 60% of the records, get to the provider at the first visit. So this is an area that we really must improve on, and we have to, really establish programs that our hospitalists follow when they do a discharge. And I tell hospitalists, spend a few minutes, make a phone call. I know it's old-fashioned, but if you make a phone call to that provider, the provider is not going to forget that that patient, may show up, and you may only have time to discuss the major problem, but at least they'll be waiting for the patient and know what the major problem is. So we may take 2 steps forward, but we have to take a step backwards, and some of the old techniques might be more important, and we should not forget them. Thank you for that question.
Thank you. So the next question that's come in is in regards to the just culture that you talked about. And the question is, for those hospitals and environments where there is a little bit more blame, how can administrators help staff believe that no one will be punished for reporting?
Great question. We saw from the survey that there was, in the 40% ranges of people who felt positively about, a culture of non-punishment. I think it's really up to the administrators and the managers to really be totally available. And as I said before, have conversations with these people. Let the people come into their office and talk about things. And then if you have examples where there's a near miss or a mistake that was made by, a human error or slip up, I think they should commend those people for speaking up. And it's really only through the trust of the administrators that we're going to get the people, on the front lines in the trenches to believe that they can report things without punishment. So they really have to do this by example and show how people can do this, and they can actually even think of these people as giving a positive result, and maybe even these people who do report it can get involved in the root cause analysis to try to fix the problem and be part of the solution rather than part of the problem.
Great. Thank you very much. Well, that's all the questions that we have here today. If you come up with any other questions, feel free to email me, and I'd be happy to pass those along to Dr. Mackles to address. Otherwise, we appreciate your time today. Dr. Mackles, thank you so much for this presentation. We will put this recording available on our website, so you can check it out in our archived section. We will also email out the link to this archive. So with that, Dr. Mackles, thanks again for your presentation. Everyone have a lovely week, and we look forward to seeing you next time.